That's a very tough act to follow here, but my name's Paul Bryar, and the second part of the title is Update on Diabetic Retinopathy, talking about understanding healthcare disparities. And I always like to segue one topic to the next. One of my purposes is to look at healthcare disparities. I practice at a university, but also at a community health center, and I see diabetes and diabetic retinopathy every day, trying to take, the disparities that I see on a micro level and look at them on a macro level, and that's what we're going to be doing here today, and trying to understand them so we can address them. I have some funding that was listed there, NEI funding for this specific type of work, but I'm looking at healthcare disparities in Chicago where I practice, okay? When we think of diabetes, this group knows there's many people with diabetes, 37 million in the United States. The cost, annual cost is $237 billion, and there's 7.7 million individuals in the U.S. now with diabetic retinopathy, and that's expected to increase by almost 50% within the next decade. Okay, so. I'm also a pathologist, so I couldn't get away without showing you one past slide in this one here. But we know that we have normalized, we can see preclinical evidence, but our job is to look at diabetes and try to prevent going farther to the right, to the vision-threatening retinopathy. And that's what we're going to be talking about here, okay? So in terms of diabetes, this is how I was taught to think of diabetes and retinopathy. What are the risk factors, for this? Hemoglobin A1C, that's what comes to my mind. Duration, how long have you had diabetes, okay? There are other things that we talk about, hypertension, hyperlipidemia, ethnicity does have a role, pregnancy, but in terms of that, smoking, there is some evidence of that, okay? But what are the risk factors that we're looking at? That's what I'd like to know is why are there disparate areas of diabetic retinopathy, okay? And so one of the things we got to thinking is why is it more prevalent in areas, in underserved areas? So one short study that we did was looking at insurance coverage, okay? And we wanted to determine whether socioeconomic status is associated with higher prevalence and severity of diabetes, okay? And what we use for that is our proxy for that was Medicaid. In Illinois, as in most tests, in most states, you have to be means tested to qualify for Medicaid. So that's what we were looking at as our proxy. And we looked at presence of any retinopathy, okay, severity of retinopathy, and hemoglobin A1C after the initial visit, okay? So we did this with all of our patients in our system with diabetes that had established care that we could follow. So this was over 6,000 patients that we looked at. And we found that among patients with Medicaid compared to those with other types of insurance, I think this battery might be, I think we have the same issue with the battery here. There we go, okay. Diabetes, prevalence of diabetes was higher in Medicaid than with all other types of insurance, okay? And in patients with Medicaid, it was also, the severity was higher, okay? Significantly higher in both of those things. And we looked at hemoglobin A1C. Can we just say that they're more poorly controlled diabetics? That is true that they do have a higher A1C, but not by much, 7.7 versus 7.4. It was significant, but are there other things? And yeah, A1C may not be the only reason for this increase, okay? So that was, what we looked at, and this just shows graphically, all types of retinopathy, all vision-threatened retinopathy are more common in this group of patients compared to others, okay? So what we also looked at is, well, A1C side by side with Medicaid, and we looked at the percent increased risk of retinopathy with Medicaid was more significant, factor in our population of patients. Hemoglobin A1C, as it got higher, it did confer, a higher risk, but eventually those two may meet, but it's not the whole picture, okay? So this was just a short thing that when we look at healthcare systems, right? We want to, who do we need to screen? You know, we screen patients, we'd like to screen all patients with diabetes, but if 50% of our patients are not getting screened, who do we go after? Well, those with high A1Cs, perhaps it's a very easy identifiable field in our EHRs where we can do that using Medicaid. So we looked a little bit further into this in Chicago where I practice, you know, so this is just a map, you know, picture of Chicago followed by a map. And I want to show you this map because we're going to be going back to this one several times. So Chicago, for those you may or may not know, is it lends itself very well to studying these type of disparities for some reasons, historic reasons, where a lot of the wealth and the poverty and the violence that we hear about is concentrated in very small areas, right? So looking at this picture, about 220 zip codes in Chicago, those with the darker blue are the ones where the federal poverty level is highest, okay? And if you look at that, where I have that red circle, that's kind of the center of downtown. The south and the west sides of the city are where all these, most of the poverty in Chicago is concentrated, okay? And we wanted to look at where can we look at the greatest disparities in diabetic retinopathy, okay? And we used we're fortunate in we have a cooperative program where all of the 6 major academic medical centers, the county health system, we were able to share our data in something called HealthLink. So we're able to look at this on a region-wide, you know, level. Okay. So HealthLink, it's de-identified clinical data, so we could look at it. Our study was IRB approved, and we looked at 2 million patients. So this is a very big study with a decent amount of power to do this. So we looked at patients who were established in Chicagoland, who lived there and who were over 18, and 1 million of those patients met the criteria. So now we're looking at over 140,000 patients with diabetes and over 11,000 patients with diabetic retinopathy. Okay, and so what did we find? We wanted to know where is the greatest prevalence of diabetes, right? Where is the greatest risk of retinopathy? And finally, where's the greatest amount of undiagnosed retinopathy? Because that's where we want to target our efforts. So here's what we found. So and we were looking at basically highlight. We want to see in each of those zip codes. What is the expected retinopathy? Okay, and this is where I like to, how do we do this? Well, when we talk about baseball, right? So I'm a baseball fan, and I live 4 blocks from Wrigley Field, so I can hear the difference between a single and a home run. We use similar, sabermetrics as a statistical analysis of baseball. So you see on the left hand, that's every hit that Chris Bryant had in a period of time. So we know where the fly balls are, where the outs are, where the hits are, right? Because if we can predict where those hits are going to happen, that's where we can place our fielders there. So this map here is looking at the percent of people in every zip code with diabetes. Okay, so the bigger dots have more patients with diabetes than the smaller dots. Okay, and so when we take that original map that we looked at, the dark blue is just in the background. Those dots haven't moved, but the dark blue areas are the ones with higher levels of poverty, patients at or below the federal poverty level. Okay, so we see that those bigger dots, not surprisingly, tend to be in the dark blue areas. Okay, so that's just patients with diabetes, and there was a correlation with that. Let's look at diabetic retinopathy. And so the way we looked at this is we looked at predicted retinopathy per zip code. We took each of the zip codes, looked at census data, controlled for age, race, and other factors, right? And we looked at the actual retinopathy rate, okay? So when we have that, where the actual approaches the predicted, that means we're screening appropriately, we're finding diabetes. So that would be a small dot on the next map that we're gonna see, okay? In areas where there actual rate of retinopathy is lower than undiagnosed retinopathy, that's where we have underdiagnosed retinopathy. So that's where the greatest disparity is. We have patients that have the disease where they don't know it, okay? And that's where on the next map, you'll see the big green dots, okay? So here's what our map looks like. So each of those green dots are areas where we have the highest rate of undiagnosed retinopathy, right? So we know that, and again, those are all concentrated for the most part on the west and the south sides of the city, which happen to be that same poverty map that we're looking at there. So using our baseball analogy, if I'm Dusty Baker managing the Houston Astros and I want to find out where to position my players to find this retinopathy, right, that's where I'm going to go to, okay? So that's how we can use this type of statistical method with precision down to, you know, a 6-block square area and say, this is where we need to go to find these diseases that are undiagnosed, causing blindness in our own backyard. And this can be taken out of Chicago and put into any, you know, any type of center, okay? So what we did is we looked at, we wanted to see what is a risk, what are these areas of risk, and what are the ideal places versus places where we want to spend our time. So an ideal zip code would have low risk of diabetes, a low risk of retinopathy, but a high rate of diagnosis. That means it's the patient with diabetes there, we know they have retinopathy, and we're finding all of it. Those are ideal zip codes, right? That's where, if you have diabetes, that's where you want to be. On the other hand, if we look at what we call high-risk zip codes, right? You're going to have high rates of diabetes, high rates of retinopathy, high risk of retinopathy, and a low rate of diagnosis, okay? And that's where we look at here. And if you just, with the numbers of the 200, more than 220 zip code, those zip codes that are the high risk, there's only 36 of them, you know, so. And what do we find? So here's the ideal ones, right? Low diabetes, low retinopathy, and high rate of diagnosis, right? 67 of the zip codes. We looked at the percent of minority populations in each of those 67 zip codes compared to the Chicagoland average. You know, about 50% minority is average for Chicago. These ones are 32%, so that was significantly less minority. And if we look at poverty, you know, next to that, only 10% of those people in that zip code lived at or below the federal poverty level versus the Chicagoland average, which is, you know, almost 18%. So that's what happens in the ideal zip codes. You know, when we flip this over to look at those high-risk zip codes, right, where we have high diabetes, high retinopathy, and a low rate of diagnosis, there's only 36 of those zip codes, right? And we found that much significantly higher percent minority and almost double the poverty level, right? So we know that's where we have to target there, and this is the demographics of those zip codes, okay? So in summary, we know that in our area, disparities exist, you know, in a tight amount of zip codes with regards to diabetes, retinopathy, and the likelihood to be diagnosed, okay? And this is where we can target our screening, right? And so when we think about this, isn't this just race? You know, is this ethnicity, you know, or genetics? Are we just discovering this because people, you know, somewhere people live in similar zip codes? And you know, how do we think about that? Probably yes, and probably no, and to some degree both. And this is from, you know, I'll just read this out. It says, it is important to note that, you know, race is a socio-political construct, not a biologic determinant of disease, and is often assigned on the basis of varying and inconsistent criteria, such as phenotypic or self-reporting. So the data we have on this is what patients tell us, which may or may not, they may withhold information, they may be inaccurate, or you know, so. And this was the Academy of Ophthalmology's task force on disparities. You know, so we have to look at this just a little bit differently. And so I'm not a glaucoma specialist, but as I look into this area, you know, just to demonstrate that it might not just all be genetics, right? So let's look at air pollution, okay? There's one of the most common things is a particle called PM2.5, okay? World Health Organization says that exposure to air pollution is one of the main global burdens of all disease, okay? So, and when we look at PM2.5 exposure by race in the United States, so the way you read these graphs are, each of those graphs, there's what's called a line of equity. So if you're below that, you have less exposure. If you're above that line, you have more exposure, okay? And so if we look at, in this study, the white population, they were all below, that PM2.5, okay? If we looked at all persons of color across all the zip codes in the United States, they're above, right? And even if you parse out different ethnicities of the persons of color category, Black and Hispanics tend to be above. And we said, well, is this just race, or is this also, is this income level? And so the authors here also controlled for income, and we found that persons of color were still, no matter what their income was still above that line of equity, right? So, and how do we talk about that? What do we look at that scientifically? So, well, looking at PM2.5, and I said again, bring this back to glaucoma, right? So, there's the study I'm quoting, higher 2.5 are more likely to report a diagnosis of glaucoma, right? And if you look at it even closer, when you look at those higher levels of PM2.5, correlates with thinner ganglion cell layer, inner plexiform layer thickness, which is a finding that we see in glaucoma with a very, very high statistical significance. So, so this is not all glaucoma causing this, but this is just an example of how this may not just be race and ethnicity and genetics that we're looking at, to describe this. So why is that? Well, in our area where I work at, it has to, probably due to where are these high pollution centers placed, right? And if you look at where those are placed, they're placed in all those blue areas in the map. So, and so to, kind of conclude when I think of diabetes and when I go to my clinics looking at that, how can we look at disparities in diabetic eye care? Well, if it's one thing that we talk about is the social determinants of health, okay? And the social determinants of health is one of the main focuses of the National Eye Institute's, Healthy People 2030, initiative. And so we look at economic stability, education and access, healthcare access, okay, neighborhood and built environment, and social community context, okay? So how much do social determinants of health matter? And I still don't have an answer to this question, but, and American Journal of Preventive Medicine, a study looked at two things. What do similar metrics have to do with two things on overall health outcomes? Length of life and quality of life. Those are the only two things they looked at here. So it's not a specific disease. And they looked at things very similar, but not exactly identical to social determinants of health. So they took, there's our social determinants on the left. They combined economic stability and social community context, right? Then they took health behaviors. Are they smoking? Are they not? They looked at another one of our social determinants, healthcare access. So they said clinical care. How close are you to a hospital? And what are the, that was one of the main things. What is your access to care in terms of insurance? They looked at physical environment as well, right? And so they looked at those four things and says, just those four things, what is the overall benefit on those two outcomes, length of life and quality of life, okay? And what is the relative contribution of each of those four things? So they found very interesting. Their number one was social and economic factors. We had the highest correlation with length of life and quality of life, okay? Health behaviors, are they smoking, are they healthy, are they exercising, had the next highest. A distant third is clinical care, so how close are they to a hospital system? So that does have some impact, but, and then physical environment was down there. So, to me, it's very eye-opening to think of medicine this way when I'm taught, what's your hemoglobin A1C? How's your blood pressure? Are you taking your medicines, right? And that's how I typically encounter and counsel people with diabetes every day. But their conclusion was that the greatest improvements in population health, right, would be addressing the social and economic determinants of health. And I think that's where we have to start, thinking of this in where I live, if I'm going to help address these disparities. So getting back to the diabetes, what we wanted to know, what are the risk factors? Do we need to rethink the order? This is the order that I came up with before I got into this. Well, what are the factors here? I think we do have to add in, the social determinants of health, Medicaid, maybe those things have to be higher on our list of how we think of this and how we can address the disparities that exist. And with that, I'm going to stop and see if there's any. Thank you. I just want to acknowledge my collaborators here. This was multi-year work, and I appreciate working with all of them.
So, any questions, please?
Paul, thank you. Paul, thank you for presenting a very hot topic in Chicago and just tons of work to get to this point. But I just was wondering if you could comment on the non-meteoradic camera screenings that you've had through the community health centers, and if you could just touch a little bit on that. Thanks.
Yeah. So we as a nation screen about over 65% or so patients with diabetes get their eye exam once a year. So looked at either by a photo or an exam. In some populations in the underserved, it's probably about 35 to 45%. So how do we get there? Do we keep telling them you have to come in once a year for an eye exam? And that's hard for us to do. We are very good, though, however, as a system, relatively good about getting them in and getting them medicine and having them take A1C. So we look at where non-meteoradic screening is something that we're doing, and that's where we're applying those metrics. And we replaced 5 cameras in community health centers with very good precision into each of those zip codes, and some of those zip codes are maybe 5 square blocks. So it's a pretty precise geolocation of where to put those cameras. So that's how we're doing that, and now we're looking at what the downstream impact will be on that right now. But that's still ongoing. So.